Post-traumatic facial palsy is a critical complication of temporal bone trauma, leading to varying degrees of facial weakness or paralysis. Early recognition and appropriate management are essential to improving patient outcomes. The facial nerve, cranial nerve 7, has a long and complex course, making it vulnerable to injury at multiple sites along its path. Studies indicate the following site-specific involvement in trauma: 66% at the geniculate ganglion, 20% at the second genu, 8% in the tympanic segment, and 6% in the mastoid portion. The geniculate ganglion is the most commonly affected site due to its sharp anatomical turn, making it particularly vulnerable to fracture impact and direct trauma. To understand the impact of trauma, let's quickly review the anatomy of the facial nerve as it travels through the temporal bone. The intracranial segment originates at the brainstem. The internal auditory canal travels with the vestibulocochlear nerve. The labyrinthine segment is the shortest but most vulnerable to ischemic damage. The geniculate ganglion is the most common site of traumatic injury. Located at the sharp turn between the labyrinthine and tympanic segments, the tympanic segment runs horizontally along the medial wall of the middle ear, and the mastoid segment passes through the mastoid process before exiting via the stylomastoid foramen. Because of these multiple bends and narrow canals, trauma can cause compression, swelling, or complete transection of the nerve, leading to varying degrees of facial dysfunction. Facial nerve damage and trauma occurs primarily due to temporal bone fractures, classified as longitudinal fractures, which account for 70 to 90% and run parallel to the petrous ridge, often sparing the facial nerve but may cause conductive hearing loss due to ossicular chain disruption. When facial nerve involvement occurs, it is usually incomplete and delayed. Transverse fractures, which account for 10 to 30%, are perpendicular to the petrous ridge, often involving the cochlea and vestibular structures, with a higher likelihood of immediate and complete facial nerve paralysis, often resulting in sensory neural hearing loss due to inner ear involvement. Blunt trauma, penetrating injuries, or iatrogenic causes can also result in direct nerve injury. The symptoms depend on the site and severity of injury, with immediate paralysis suggesting nerve transection, whereas delayed paralysis is often due to progressive edema or ischemia. Incomplete paralysis has a better prognosis, often improving with conservative treatment, while associated symptoms depend on the affected segment, including taste disturbances, hyperacusis, and reduced lacrimation. The House-Brackman grading system helps assess facial nerve function, ranging from normal function to severe to total paralysis. Accurate diagnosis requires a combination of clinical evaluation, imaging, and electrophysiology, including clinical examination to assess facial movements and asymmetry, CT scans to identify temporal bone fractures and nerve compression, MRI for soft tissue evaluation, and electrophysiology tests like electroneuronography and electromyography to evaluate nerve function and predict recovery. Treatment is guided by severity and timing of the nerve injury, with conservative management for incomplete paralysis or delayed onset involving high-dose corticosteroids, facial physiotherapy, and artificial tears for eye protection. Surgical management for complete paralysis or confirmed nerve disruption may include facial nerve decompression, nerve grafting, or hypoglossal facial anastomosis. Incomplete paralysis has a favorable prognosis, often resolving within 3 to 6 months, while complete paralysis has variable outcomes depending on nerve integrity and timely intervention. Early diagnosis and management significantly improve functional recovery. In summary, post-traumatic facial palsy requires a detailed anatomical understanding, precise diagnostic evaluation, and a tailored management approach, with the geniculate ganglion remaining the most vulnerable site, and timely intervention making a crucial difference in patient outcomes.